Okay, let's start with a statistic that really drives home the stakes here. Scaphoid fractures. This small bone in your wrist, it's the most commonly fractured carpal bone, making up something like 60% of all wrist bone breaks.
That's right. A huge proportion.
And you might think, all right, a simple wrist break after a fall. But here's the critical part, depending on where it breaks, how it's treated. Well, a significant percentage, potentially 15 to 50% overall, maybe even hitting 100% in those tricky proximal pole fractures if not handled correctly, can lead to a vascular necrosis.
Essentially bone death.
Exactly, bone death. That seemingly simple fall can just unravel into chronic pain, loss of function, maybe even a career-threatening problem for someone relying on their hands.
And so much of that risk comes down to the scaphoid's peculiar structure, that sort of twisted peanut shape we talk about.
Right.
And its notoriously complex, almost awkward blood supply.
Welcome to the deep dive. This is where we take complex information research papers, clinical guidelines, expert knowledge, and really extract the vital insights, giving you the shortcut to being truly well-informed. Today, we are taking a profound look into scaphoid fractures, navigating the orthopedic knowledge and clinical practices necessary to understand and manage this, well, really challenging injury. And guiding us through this deep dive is Professor Mo Imam, a distinguished expert in musculoskeletal trauma and hand surgery. Professor Imam, it's a real privilege to have you join us.
Thank you. It's a crucial topic, and I'm glad to explore it. The scaphoid is, well, it's a small bone that presents some very large clinical problems if not understood properly.
Absolutely. So to kick things off and maybe give you a roadmap of where we're heading, let's hit you with 3 quick high-impact questions.
Okay.
First, just stepping back, what exactly is a scaphoid fracture? And fundamentally, why does it pose such unique problems compared to, say, a break in the radius or ulna?
Well, what's critically important here is the scaphoid's unique anatomy and its vascularization. You see, it's the critical mechanical link between the 2 rows of wrist bones, absolutely essential for smooth motion. But unlike most bones that have multiple points of entry for blood vessels, the scaphoid gets the majority of its blood supply through quite a limited area, often distal to where the fracture occurs.
Okay.
Which means the blood has to flow retrograde backwards towards that vital proximal pole. This sets it apart entirely from breaks in the long bones of the forearm.
That retrograde flow sounds like a built-in vulnerability, doesn't it?
It absolutely is.
Second question then, beyond just the initial break healing, what are the most significant, potentially devastating complications that professionals, especially those who use their hands intensely, must absolutely be aware of?
Yes, this really raises the specter of long-term disability. The primary complications are nonunion, meaning the fracture simply fails to heal,
Right.
and avascular necrosis, or AVN, where the bone tissue actually dies due to that lack of blood supply.
Okay.
Either of these can lead to malunion, where it heals crookedly, progressive carpal collapse, and ultimately debilitating osteoarthritis of the wrist. These aren't minor setbacks. They really can be career-ending issues.
Non-union and AVN, those are the big risks. Okay. Finally, if you had to boil it all down, is there one single most critical factor in achieving a good outcome for a scaphoid fracture?
That's a key question. If we distill all the evidence and, clinical experience, the single most critical factor is probably an early, accurate diagnosis.
Right.
Followed immediately by appropriate individualized management. And that management has to be based on a thorough assessment of the fracture characteristics. Hesitation or misdiagnosis significantly increases the risk of those complications we just mentioned.
Early, accurate diagnosis and appropriate management. Sounds like a bit of a race against the clock and the anatomy itself.
In many ways, yes.
So let's start by understanding the star of our show, the scaphoid bone itself. We often hear it called boat-shaped from its Greek origin, but you prefer twisted peanut. Why is that shape significant?
Indeed, oscaphoidium does translate to boat-shaped, and I suppose if you look at it from one angle, maybe it vaguely resembles a small boat. But the twisted peanut analogy, while less scientific, perhaps gives you a better sense of its complex 3D geometry and its angulation. It's not a simple straight bone.
Okay.
This shape is crucial because it has 2 main articulating surfaces, fitting neatly into the proximal and distal carpal rows. And the vast majority of its surface, over 75%, is covered in smooth articular cartilage, which is essential for wrist movement.
Right, for the gliding.
Exactly. But this also means there's very little raw bone surface available for soft tissues, ligaments, or, critically, blood vessels to attach and actually enter the bone. The main area where blood vessels can get in is a small, non-articular area known as the dorsal ridge.
So the very structure designed for smooth movement actually limits where its lifeblood can get in.
Precisely. It's a trade-off.
Let's dive deeper into that critical, tricky blood supply, maybe drawing on that foundational research. What did the classic Gelberman and Menon study from 1980 using those latex injections really reveal about the scaphoid's vascularity?
Ah, yes. That study, published in the Journal of Hand Surgery, was absolutely seminal. It meticulously mapped the scaphoid's blood supply. They identified two primary sources, or vascular leashes, as they call them.
Okay.
The dominant supply comes from the dorsal ridge artery. Now, this is a branch of the radial artery, and it's responsible for a significant majority, perhaps 70 to 80% of the scaphoid's total blood flow. It enters the bone through that non-articular dorsal ridge we just discussed.
The small entry point on the back, and this is where the retrograde flow comes in, correct?
Precisely. The blood vessels entering the dorsal ridge predominantly supply the distal and middle parts of the scaphoid first.
Okay.
So to reach the crucial proximal pole, that's the part closest to the forearm bones, the blood has to flow backwards, or retrogradely, up the length of the bone. It's quite counterintuitive compared to how blood typically flows into most bones.
So blood comes in effectively at one end and has to push upstream to reach the other end. That seems inherently risky.
Exactly. Now, there is a secondary minor supply from the palmar side via branches of the palmar and superficial palmar radial artery. These vessels enter near the distal tubercle and supply roughly the distal 20 to 30% of the scaphoid.
Okay, so combining these, you've got the main supply coming in dorsally, flowing retrogradely, and a smaller supply coming in palmarly just to the distal bit.
That specific setup creates a significant vulnerability. The area reliant on that retrograde flow, particularly the proximal pole, is effectively in a watershed zone.
Watershed zone, right?
So if a fracture occurs between where those dominant dorsal vessels enter and the proximal pole itself, that proximal fragment can be entirely cut off from its blood supply.
Completely isolated.
Yes, and the small palmar supply is usually insufficient to sustain it. This is the fundamental anatomical reason why proximal pole fractures are at such a high risk of vascular necrosis. The blood simply can't get there.
That anatomical detail is just incredibly important for understanding the prognosis, isn't it?
Absolutely fundamental.
Now, turning to how and where these fractures typically happen, what does the epidemiology tell us? Who gets these and why?
Well, epidemiologically, scaphoid fractures are, as you mentioned right at the start, the most common carpal fracture. They make up about 60% of all carpal breaks and maybe 15% of acute wrist injuries generally.
Okay.
The highest incidence is in young, active men, particularly in their third decade of life. The male-to-female ratio is often cited around 2.1.
So it's often associated with activities then, sports, falls.
Absolutely. The overwhelming etiology of the cause is a fall onto an outstretched hand, the classic foosh injury.
Poosh, right.
This mechanism typically involves the wrist being forced into hyperdorsiflexion, often with an axial load pushing down some pronation and frequently concurrent ulnar deviation, the wrist bending towards the little finger side.
That's the classic scenario, isn't it? Tripping, falling off a bike.
Exactly. Sports, falls from height, or simply tripping on the pavement.
Yeah.
It's worth noting, too, that this foosh with ulnar deviation can also simultaneously injure ligaments around the wrist.
Yeah.
Sometimes it leads to what we call a DISI deformity, dorsal intercalated segmental instability.
Okay, what does that mean?
It essentially means the middle row of carpal bones tilts backwards abnormally, which adds another layer of complexity to the injury.
Right, so it's not just the scaphoid break. That makes sense. And where in this twisted peanut does it most commonly break? You mentioned the proximal pole is riskiest, but is it the most frequent?
No, interestingly, while the proximal pole is the riskiest spot for complications, it's not the most frequent location for the fracture itself. The most common fracture location is the waist, the narrowest part of the bone. That accounts for about 65% of scaphoid fractures.
The majority, then?
Yes. Fractures in the proximal third are next most common, at around 25%, and fractures of the distal third, or the little tubercle at the end, are the least common, making up perhaps 10%. There used to be belief that distal fractures were more common in children, but more recent large series suggest that waist fractures are now actually the predominant site across most age groups.
So the waist is the frequent flyer, but the proximal third is the high-risk passenger.
That's a good way to put it, yes.
This brings us neatly to classification systems. Why is it so vital to classify a scaphoid fracture beyond just saying it's broken?
Oh, classification is absolutely paramount because it's really the foundation for clinical decision-making. It helps us assess the fracture's stability, understand its likely prognosis, and ultimately dictates the most appropriate treatment strategy.
Whether it's casting or surgery.
Precisely. Whether that's casting or surgery, and indeed what type of surgery might be needed. A proper classification guides us towards maximizing the chance of union healing and minimizing those complications we talked about.
The Herbert classification is widely used, isn't it? It seems to be based specifically on stability and also the timing, whether it's acute or older. Could you walk us through the main types?
Yes, the Herbert classification is very clinically relevant because it categorizes fractures based on factors that directly impact treatment and outcome. It divides fractures into four main types: A, B, C, and D.
Okay.
Type A represents stable acute fractures. These are generally lower risk and include A1, which is a fracture of that distal tubercle,
The little end bit, yes.
and A2, which is an incomplete waist fracture, meaning the crack doesn't go all the way across the bone.
Right, so those are relatively safe bets for healing.
Generally, yes, with appropriate immobilization. Then you have type B, which represents unstable acute fractures. Now, these are the ones that often require surgery due to their inherent risk of not healing well or displacing.
Okay, what's in type B?
This category includes B1, a distal oblique fracture, which is prone to shear forces and slipping; B2, a complete waist fracture, which is considered unstable because it breaks the main structural support across the middle; B3, a proximal pole fracture, which we know is unstable due to that high AVN risk and the anatomical difficulty.
The blood supply issue again?
Exactly. And B4, which is a very significant injury indeed, a transcaphoid paralunate fracture dislocation. That involves major disruption of the ligaments around the lunate bone as well as the scaphoid brick itself.
Wow, okay. So type A is relatively stable, type B is unstable and problematic. What about C and D?
Type C is designated for delayed union. This is when the fracture hasn't healed within the expected time frame, say after several months of casting, but there's still thought to be some biological potential for it to heal, perhaps with further immobilization or maybe some intervention.
So slow healing, but not given up yet.
Precisely. And then type D is for established nonunion. This means the bone has failed to heal, the healing process is effectively stopped, and it requires intervention to achieve union.
And Herbert breaks down non-union further.
Yes, Herbert further subdivides nonunion, which is useful prognostically.
Mhm.
D1 is a fibrous union, where there's maybe some soft tissue connection but no solid bone bridging the gap. D2 is a pseudarthrosis, which literally means a false joint with instability and often early deformity starting to develop.
Like it's moving where it shouldn't.
Exactly. D3 is a sclerotic pseudarthrosis, which is a more established false joint where the bone edges have become hardened and dense, often with significant deformity like that humpback shape. And finally, D4 indicates avian avascular necrosis associated with the nonunion, often presenting as a fragmented or collapsed proximal pole.
That progression to D4 sounds like the real end stage of that AVN risk we discussed right at the start.
It often is, yes. It represents significant biological failure.
Are there other classification systems that clinicians use alongside Herbert?
Yes, there are others that focus on slightly different aspects, which can be complementary. The Mayo classification is a simpler system based purely on the anatomical location. Type 1 is the distal tubercle, Type 2 the distal articular surface, 3 the distal third, 4 the middle third or waist, and Type V the proximal third.
So just location.
Just location. And the Rust classification describes the fracture line pattern or its orientation: horizontal oblique, transverse straight across, and vertical oblique.
Why does the pattern matter?
Well, a vertical oblique fracture pattern, for instance, is a known risk factor for instability and nonunion. Because the fracture line runs more vertically, it's much more prone to shearing forces when the wrist is loaded, making it harder to hold reduced and less likely to heal in a cast.
I see. So Herbert gives you the stability and chronicity picture, Mayo gives location, and Russ adds the fracture pattern detail, and combining these helps make the treatment decision.
Exactly. The classification, drawn on these different aspects, directly informs the management pathway. Stable, undisplaced fractures, typically Herbert type A, or maybe non-displaced type B2 or B3, depending on surgeon preference and careful imaging, and often Mayer-Ruth types without displacement or vertical patterns are usually candidates for non-operative management with casting.
Okay.
Whereas unstable acute fractures, Herbert type B, vertical oblique patterns, any proximal pole fracture really, those with significant displacement or angulation seen on imaging almost always require operative intervention due to the high likelihood of nonunion or malunion if you simply put them in a cast.
Right, the classification is absolutely the roadmap to treatment. Now, let's talk about actually spotting this injury in the first place. Given there's often no dramatic deformity, how do clinicians typically diagnose a scaphoid fracture? What are the key clinical signs to look for?
Clinically, the cardinal sign, the one everyone learns, is tenderness in the anatomical snuff box.
That little hollow on the back of your wrist?
Exactly, on the thumb side, formed when you extend your thumb out. Pressing firmly in that area after a fouche injury is highly suggestive. Its sensitivity for detecting a scaphoid fracture is reported to be high, maybe up to 90%.
That's quite high.
It is, but it's crucial to remember that other injuries, like ligament sprains or fractures of the radial styloid, can also cause snuff box tenderness. So it's sensitive, but not perfectly specific. It doesn't absolutely confirm a scaphoid fracture on its own.
Okay, so it's a strong clue, but not proof. What else?
Other signs include general swelling around the radial side of the wrist, often some reduced range of motion, particularly wrist extension and radial deviation. Pain with forceful resisted pronation of the forearm can sometimes elicit pain. And there's a positive scaphoid compression test, where you push axially along the line of the thumb metacarpal towards the wrist, and that reproduces their specific pain.
Right.
But the key challenge, as you said, is that unlike, say, a broken forearm bone, there's usually no obvious deformity. The wrist might look a bit swollen, maybe bruised, but often not dramatically out of shape. This makes it really easy to mistake for a simple wrist sprain, especially in the heat of the moment, like on a sports field or in a busy A&E.
So the take-home is, after a fall onto an outstretched hand, if there's snuff box tenderness, you really should have a high clinical suspicion. What's the crucial next step then in terms of imaging?
The standard initial imaging is plain X-rays, but, and this is a really important point, you need the right views to maximize the chance of actually seeing the fracture, especially if it's subtle or undisplaced.
Not just the standard 2 views.
No, definitely not. Relying on just standard PA, posterior-anterior, and lateral views is often insufficient. The sources consistently recommend a minimum of 4, or ideally 5, specific views. This includes the standard PA and a true lateral.
Okay.
But crucially, also PA views taken in 45 degrees of oblique pronation and 45 degrees of oblique supination. And the PA view taken with the wrist in maximum ulnar deviation bending towards the little finger.
Why the ulnar deviation view?
That specific view helps to elongate the scaphoid, straightening out its natural curve on the X-ray image, which makes fractures across the waist much more visible than they might be in the standard neutral PA view.
Right, it sort of uncoils it visually.
Exactly. And beyond just looking for the fracture line itself, on the X-rays you also look for other radiographic signs, things like sclerosis, which is increased bone density along the fracture line, suggesting poor healing or maybe even early bone death. Or looking for that humpback deformity on the lateral view, which is an increased intrascaphoid angle.
How much of an angle is abnormal?
Generally, an angle over 35 degrees suggests some deformity, and an angle greater than 45 degrees is strongly associated with poor outcomes and the likely development of that dizzy instability pattern we mentioned earlier.
Okay. Now, there's the historical approach, the 2-week delay, where initial X-rays are negative, but your suspicion is high. You cast the wrist and repeat the X-rays 2 weeks later. What was the thinking behind this, and is it still the recommended practice today?
This was a very common practice for many years, based on the idea that bone resorption, a natural process occurring around a fracture line in the early healing phase, might make a previously invisible occult non-displaced fracture become visible on a follow-up X-ray after a period of immobilization.
The line might become clearer.
That was the theory. However, evidence, such as that quite pivotal 1981 Leslie and Dixon study of the JBJS, has really challenged the utility of this approach. They reviewed a large series of patients presenting with scaphoid fractures and found that a staggering 98% of these fractures were actually visible on the initial radiographic series, provided that adequate views, those multiple views we just discussed, were obtained.
98% were visible initially.
Yes. Only a tiny 2% became apparent only on the later X-rays, and these were typically only very minor incomplete fractures located on the concave side of the bone.
So the vast majority are there to be seen if you look correctly the first time. What's the implication of that finding for the whole 2-week delay strategy?
Well, the implication is pretty profound, really. Waiting 2 weeks misses almost nothing that wasn't truly visible initially, and only picks up a very small number of potentially insignificant, incomplete fractures later on. But crucially, what it does do is it delays definitive diagnosis and potentially the appropriate treatment for a full 14 days. During that delay, a fracture that might have been minimally displaced could become more displaced within the cast, or the optimal window for early surgical fixation, if indicated, could be missed. This potentially increases the risk of nonunion and AVN.
So, paradoxically, the 2-week delay, meant to avoid missing things, could actually be detrimental by delaying definitive management.
In many cases, yes, it delays certainty.
So, what are the modern preferred alternatives if clinical suspicion remains high despite negative initial x-rays? What should be done instead of waiting 2 weeks?
The modern approach, which is supported by higher quality evidence and much better technology, is to move swiftly to advanced imaging if those initial x-rays are negative, but your clinical suspicion of a scaphoid fracture persists.
Advanced imaging meaning CT or MRI.
Exactly. The primary alternatives are CT or MRI. CT is widely available, relatively quick, and generally less expensive than MRI. It's excellent at definitively demonstrating the presence or absence of a fracture line, even subtle ones.
And MRI.
MRI is even more sensitive, particularly for detecting truly occult fractures, those not visible on X-ray, or even sometimes CT, especially in the very early stages after injury, say within the first 24 to 48 hours.
Let's break down the utility of CT and MRI a bit further then. What specific information does a CT scan give you that plain X-rays perhaps can't?
CT is invaluable for assessing the fracture in fine detail. It provides high-resolution images, typically using very thin 1 millimeter slices, which are often reconstructed in the sagittal plane along the scaphoid's long axis.
Okay.
This allows for really accurate assessment of the precise fracture location, the degree of angulation or deformity, and crucially, the amount of displacement between the fragments. Displacement of greater than 1 millimeter is widely accepted as a key indicator of instability and a strong predictor of poor outcome with non-operative treatment alone.
So CT is best for measuring that gap.
Yes, CT is far more effective than X-rays, bone scans, or even MRI for precisely measuring displacement. It's also excellent for monitoring fracture healing progress over time, or for assessing the characteristics of an established nonunion before planning surgery.
And MRI, you mentioned its high sensitivity for occult fractures. What else does it offer?
MRI is really the gold standard for diagnosing those subtle or occult fractures that just aren't visible on X-rays or sometimes even CT. It detects bone bruising. An occult fracture is essentially a severe bone bruise very early on. It can also show early signs of AVN.
The blood supply issue again.
Exactly. AVN shows up as a characteristic low signal intensity on both T1 and T2 weighted images. MRI is also superior to CT for evaluating associated soft tissue injuries like ligament tears, particularly the scapholunate ligament, which can contribute significantly to overall wrist instability.
So if you have high suspicion and a negative X-ray, an MRI gives you a definitive answer about whether a fracture is present or not.
In most cases, yes. It often prevents the need for prolonged, unnecessary casting based on suspicion alone, which has implications for patient convenience and healthcare costs.
What about bone scans? You mentioned CT is better for displacement. Are bone scans still part of the diagnostic algorithm at all?
Bone scans, or scintigraphy, are highly sensitive for detecting increased metabolic activity associated with any bone injury, including fractures. They typically become positive about 72 hours after the injury. They have high specificity, around 98%, meaning if it's negative, you likely don't have a fracture.
Yeah.
But they can show increased uptake for other reasons besides the scaphoid fracture, inflammation, arthritis, other injuries leading to a 5–15% incidence of false positives.
Okay.
So while sensitive, MRI is generally considered more sensitive and more specific for diagnosing occult scaphoid fractures, and importantly, for identifying early AVN. This makes MRI the preferred advanced imaging modality in most cases where suspicion remains high despite negative X-rays.
Okay, that makes sense. So the modern approach is high clinical suspicion plus proper initial X-rays, and if those are negative, proceed quickly to CT for bony detail and displacement, or ideally MRI for occult fracture and AVN assessment, rather than relying on the old 2-week delay.
That's the current thinking, yes. Much more proactive.
This diagnostic rigor is clearly aimed at identifying instability early on. Let's just consolidate the criteria for what defines an unstable scaphoid fracture, which, as you said, is absolutely key for treatment decisions.
Absolutely. Identifying instability is paramount because it almost always mandates surgical intervention for a predictable outcome. Based on the literature and the classification systems we've discussed, the key criteria for instability include significant displacement of the fracture fragments, generally defined as greater than 1 millimeter displacement on any radiographic view, and CT is the best tool for assessing this accurately.
1 millimeter gap or step.
Got it. An intrascaphoid angle greater than 35 degrees on the lateral X-ray, indicating significant angulation and the potential for that humpback deformity. A proximal pole fracture, location, 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 which as we've hammered home, is anatomically vulnerable and often considered unstable due to the high blood supply risk, regardless of initial displacement sometimes.
Right.
Significant comminution, meaning the bone is breaking into multiple pieces rather than a clean break.
Shattered almost.
In fact, yes. Also, associated carpal instability, suggesting wider ligamentous injury. Signs of this include a scapholunate SL angle greater than 60 degrees or a radiolunate angle greater than 15 degrees on the lateral X-ray.
Indicating the other wrist bones aren't aligned properly.
Correct. And finally, of course, the most obvious instability pattern is a paralunate transscaphoid fracture dislocation, the Herbert B4 type, which is a major wrist disruption. If any of these criteria are met, the fracture is deemed unstable.
Got it. That's a clear list. High suspicion, thorough imaging, precise classification to identify instability. Now that we understand the injury and how to spot it properly, what does this all mean for getting the patient back to full function? How are these injuries actually managed?
Well, the overarching goal of management, regardless of the method, is firstly to achieve bony union healing in an anatomical position. Secondly, to relieve pain. Thirdly, to maximize functional recovery, getting strength and movement back. And perhaps most importantly in the long run, to prevent the development of those long-term complications like nonunion, malunion, and post-traumatic arthritis.
Okay.
And as we've established, the approach is broadly divided into non-operative and operative management, and the choice is driven primarily by the fracture classification, stable versus unstable, and also patient factors like age, activity level, and occupation.
Let's start with non-operative management then. When is that the appropriate route? Who gets put in a cast?
Non-operative management, essentially casting, is typically reserved for acute, undisplaced, stable scaphoid fractures.
So the Herbert A types.
Primarily, yes. This includes Herbert type A fractures, those distal tubercle or incomplete waist fractures. It can also include certain complete waist fractures, Herbert B2, or even some proximal pole fractures, Herbert B3, if they show absolutely no significant displacement, usually less than 1 millimeter, and no other signs of instability on detailed imaging like CT.
Okay.
It's also, logically, the initial approach when you have strong clinical suspicion but your initial X-rays are negative while you're waiting for or arranging that a definitive CT or MRI scan. You treat it as fractured until proven otherwise in that short interval.
Makes sense. And what does non-operative management actually entail? Is it just a standard wrist cast?
Yes, it involves immobilization in a cast, but specifically a scaphoid cast. The traditional description is a well-molded cast extending from below the elbow crease down to the hand, and crucially including the thumb, often up to the interphalangeal joint. This is often called a thumb spica cast.
Why include the thumb?
The rationale is to maximally stabilize the scaphoid bone by preventing thumb movement, as forces can be transmitted through the thumb metacarpal to the scaphoid.
Okay.
Although it's fair to say there is some ongoing debate in the literature regarding the absolute necessity of including the thumb in the cast for all types. Some studies have suggested that a simple short arm cast, without the thumb included, may be sufficient for certain stable fracture types, particularly distal ones. But the traditional widely accepted approach for waist and proximal fractures involves the thumb spica component.
Right. How long does someone typically need to be in this cast? It sounds like quite a commitment.
It is, and the duration varies significantly based on the fracture location. This directly reflects the differing healing potential due to that blood supply issue we keep coming back to.
So distal heals faster?
Generally, yes. Distal third or tuberosity fractures having a better blood supply might unite in as little as 6 weeks. Middle third or waist fractures, the most common type, typically require around 8 to 12 weeks of immobilization.
8 to 12 weeks.
Yes. And proximal third fractures, with their precarious retrograde blood supply, often need 10 to 12 weeks, sometimes even longer, maybe up to 14 weeks or more in some protocols. And even with diligent casting for that extended period, they still have a higher rate of non-union compared to waist fractures.
Wow, that's a significant period of immobilization, especially for the proximal ones. What's the follow-up protocol while they're actually in the cast? Do you just wait until the end?
No, regular follow-up is essential. Firstly, to ensure the fracture doesn't displace within the cast, sometimes called secondary displacement, and secondly, to monitor healing progress. Typically, an X-ray is taken around 2 weeks after the initial casting, primarily confirm the fracture remains undisplaced.
Check it hasn't shifted.
Exactly. Further X-rays, sometimes CT scans later on if union is questionable, are taken when the cast is planned to be removed at that estimated healing time point, 6, 8, 10, 12 weeks, etc., to assess for clinical signs of union, no tenderness, and radiographic evidence of bone bridging the fracture line. A final check, perhaps at 6 or 12 months post-injury, is often recommended just to ensure the union is stable and no late complications are developing. If union is confirmed at cast removal, then gradual mobilization, physiotherapy, and return to activity follows.
And what's the success rate for casting these stable fractures?
With appropriate patient selection, meaning truly stable, undisplaced fractures, and strict adherence to the casting protocol, the union rate for non-operative management is generally high, often quoted as exceeding 95%.
That's encouraging for the stable ones, at least. But you mentioned operative management is needed for the unstable or higher risk fractures. What are the key indications for deciding on surgery instead of a cast?
Right, operative management is indicated when the risks of nonunion, malunion, or simply a poor functional outcome with casting alone are considered unacceptably high. The primary indications are those instability criteria we defined earlier.
The list we went through.
Yes, greater than 1 millimeter displacement, that intrascaphoid angle over 35 degrees, significant comminution, or associated carpal instability like a high SL angle. Proximal pull fractures, again due to their high AVN and non-union risk and theoretical instability, are generally considered strong candidates for surgery, often requiring a specific surgical approach from the back.
So location drives surgery, too. Any other reasons?
Yes, another significant group is based on patient factors. Certain patient groups, like high-level athletes or heavy manual workers, even if they have a minimally displaced or seemingly stable fracture, might be offered surgery.
Why is that?
Because surgical fixation, particularly percutaneous screw fixation, can potentially allow for quicker union and a significantly earlier, safer return to demanding activities compared to the prolonged casting period, which might be unacceptable for their career or sport.
Get them back faster.
Essentially, yes. And finally, a delayed diagnosis if a fracture is picked up weeks or months late and it shows signs of instability or early non-union changes. That's also a clear indication for surgical intervention, usually involving bone grafting as well.
Okay, so surgery is chosen for stability, anatomical risk, proximal pull, patient functional demands, or delayed presentation. Let's dive into the surgical techniques themselves. What are the main ways surgeons fix these fractures operatively?
The two primary surgical techniques employed are open reduction internal fixation, commonly known as ORIF, and percutaneous screw fixation.
ORIF first. When is that needed?
ORIF is generally necessary for displaced fractures, significantly angulated fractures, or complex patterns where the surgeon needs direct visual access to the fracture site to clean it out, manipulate the fragments back into perfect alignment, that's the open reduction part, and then hold them there rigidly with internal fixation, usually a screw.
Okay, makes sense. Are there different ways to approach the scaphoid for ORIF?
Yes, there are two main surgical approaches used for ORIF, depending primarily on the fracture location. The volar approach, meaning coming in from the palm side of the wrist, is the real workhorse for waist fractures. It's generally preferred for these because it allows good access to the waist and distal pole, and importantly, it helps preserve that critical dorsal blood supply entering the back of the bone.
Protect the plumbing.
Precisely. The other main approach is the dorsal approach, coming in from the back of the wrist. This is usually necessary for proximal third fractures, as it provides much better direct access to that proximal fragment, which is hard to reach reliably from the front.
Right. Could you maybe walk us through the volar approach for an ORIF of a typical waist fracture? What does that involve?
Certainly. The procedure is typically performed with the patient lying supine, usually with the arm out on an arm table, and almost always under tourniquet control on the upper arm to provide a bloodless surgical field. The incision is commonly made longitudinally along the line of the flexor carpi radialis, or FCR, tendon, which is easily palpable on the front of the wrist. You carefully dissect down through the layers, protecting vital structures like branches of the radial artery and sensory nerves, and retracting the thenar muscles, the muscles at the base of the thumb, outwards. The capsule of the wrist joint is then opened, often along the FCR tendon sheath, to expose the scaphoid waist. The fracture site is identified, cleaned of any interposed soft tissue or blood clot, and the fragments are carefully manipulated back into their correct anatomical position. This reduction is often achieved and held temporarily using fine K-wires, sometimes used like little joysticks.
K-wires? Okay.
Once a surgeon is happy with the reduction, confirmed perhaps with intraoperative x-rays or fluoroscopy, a cannulated headless compression screw is inserted. Cannulated means it has a hollow core, so it can be inserted over a pre-placed guide wire. This guide wire is carefully drilled down the central axis of the scaphoid, ideally starting near the distal pole and aiming proximally across the fracture line.
Headless screw.
Yes. Headless means the screw doesn't have a traditional bulky head. It's designed so the entire screw can be buried just below the level of the articular cartilage surface. This is crucial to avoid the screw head impinging on joint movement or damaging the opposing cartilage surfaces later on. The screw is also designed with differential pitch threads to actively compress the fracture fragments together as it's tightened.
Clever design.
Very. Longer screws generally provide better fixation stability across the fracture. Now, if the fracture was significantly comminuted, meaning broken into several pieces, or if there was a pre-existing deformity like a humpback that needed correcting during the reduction, then bone grafting might be necessary at this stage.
Where does the bone graft come from?
Small amounts can often be harvested locally from the distal radius bone near the wrist incision. If a larger volume of graft is needed, it's typically harvested from the patient's iliac crest, the pelvic bone, through a separate small incision. After the screw fixation and any necessary grafting, the joint capsule and any important ligaments that were incised, like the radioscaphocapitate ligament, are carefully repaired. Then the soft tissues and skin are closed in layers.
And what happens postoperatively? Still a cast.
Yes, despite the internal fixation, a period of immobilization in a cast, usually a thumb spica, is still typically required while the bone heals around the screw. This is often for around 6 to 8 weeks, after which union is assessed radiographically, usually with x-rays or maybe a CT scan, before starting mobilization.
That sounds like quite a meticulous procedure. And the dorsal approach for those challenging proximal pole fractures, how does that differ?
The dorsal approach is quite different in terms of the structures you encounter. It's typically performed via what's called a 3-4 approach, navigating between the third and fourth extensor tendon compartments on the back of the wrist. A midline incision is usually made over the back of the wrist. The sheath containing the extensor pollicis longus, EPL tendon, the long thumb extensor is opened, and the EPL tendon is retracted radially towards the thumb side. The main finger extensor tendons, the extensor digitorum communis, EDC, are then retracted ulnarly towards the little finger side.
Okay, moving tendons out of the way.
Exactly. This exposes the dorsal wrist capsule, which is then opened, often over the scapholinate joint interval. The wrist is often flexed significantly downwards to bring the proximal pole of the scaphoid into better view. A K-wire is then inserted, usually starting just radial to the scapholinate ligament itself, aiming from the small proximal pole fragment down into the larger distal fragment, sometimes provisionally driving it into the trapezium bone distally for extra stability during screw insertion.
So coming from the top down, essentially.
Yes, aiming proximal to distal. Multiple fluoroscopic views, AP, lateral obliques, are absolutely essential throughout this dorsal approach to confirm accurate guide wire placement before drilling and inserting the cannulated screw. It's technically demanding because the proximal pole fragment can be quite small and rotated. This approach is necessary for most proximal pole fractures simply due to their location and the need to access that specific fragment directly for reduction and fixation.
Right. What are the union rates like for these ORF procedures, especially when used for those unstable Herbert type B fractures?
For Herbert type B unstable fractures treated with ORIF, the reported union rates are generally good, certainly much better than casting alone for these types, but they do vary slightly by the specific subtype, reflecting those inherent biological and mechanical challenges. Based on studies specifically using the Herbert classification, union rates for ORIF are often reported around 90% for B1 distal oblique fractures.
Okay.
Maybe 88% for B2 complete waist fractures, and slightly lower, perhaps around 85%, for B3 proximal pole fractures.
Still, 85% for the proximal pole with surgery is pretty good, but it highlights the challenge.
It does. It highlights that even with optimal surgical technique, proximal pole fractures remain biologically more challenging to heal compared to waist fractures, purely due to that vascular issue.
Now let's talk about the other main surgical technique, percutaneous screw fixation. That sounds less invasive than opening the wrist up fully.
It is, yes. And it's become increasingly popular over the last couple of decades, particularly for specific indications. Percutaneous screw fixation involves inserting the fixation screw through very small stab incisions, typically just 1 or 2, without formally opening the joint capsule widely.
What are the main advantages of doing it that way?
The key potential advantages are even faster union rates, with some studies reporting rates approaching 100% in carefully selected ideal cases. Also, potentially less time required in a cast postoperatively compared to ORAF, and consequently an earlier return to activities, including work and sport, which is a major driver for certain patients.
When is percutaneous fixation indicated then? Is it suitable for all types?
No, it's primarily indicated for acute Minimally displaced scaphoid fractures, usually waist fractures, where an anatomical reduction can be achieved closed just by manipulating the wrist and thumb, and crucially, where this position can be confirmed with high-quality intraoperative imaging.
So not for badly displaced ones.
Generally not, as you can't directly see and manipulate the fragments. It's especially appealing for patients like manual workers or athletes who have a strong need to minimize their time in a cast and return to function as quickly as possible, provided their fracture pattern is suitable, typically that minimally displaced waist fracture, which is already in good alignment or can be easily reduced closed.
How is that technique actually performed? If you're not opening it up, how do you get the screw in the right place?
The patient setup is similar. Supine, arm table tourniquet, but absolutely critical for percutaneous fixation is the use of high-quality image intensification fluoroscopy or live X-ray throughout the procedure for precise guidance.
Continuous X-ray vision.
Essentially, yes. Traction is often applied to the thumb, sometimes using a finger trap device, to help distract the fracture fragment slightly and align the scaphoid along its long axis. The wrist is positioned carefully, often in ulnar deviation, and flexed over a bolster or roll, again to bring the scaphoid into a straight orientation relative to the fluoroscopy beam.
Okay.
A small volar, palm-side stab incision, maybe only 5 millimeters long, is made over the palpable scaphoid tuberosity distally. Through this tiny incision, a guide wire is then very carefully inserted, aiming along the central axis of the scaphoid towards the proximal pole.
This sounds like the tricky part.
It is the crucial step. Multiple fluoroscopic views, AP, lateral, and those 45 degrees obliques, are used repeatedly and meticulously to ensure the wire is perfectly positioned down the central third of the bone on all views, and critically, that it's not penetrating out through the joint surfaces anywhere along its path. Once the surgeon is completely satisfied with the guide wire position, a cannulated drill is passed over the wire to create the channel, and then the cannulated headless compression screw is inserted over the wire. Often, a slightly shorter screw length is chosen compared to the measured length to ensure good compression is achieved across the fracture site as the screw tightens. Typically, screws around 24 millimeter or 26 millimeters are used for the waist.
Okay.
In some cases, particularly for longer oblique fracture patterns which might have some rotational instability, a second, parallel K-wire might be inserted percutaneously alongside the screw guide wire just to provide some anti-rotation stability.
It sounds like navigating that guide wire and screw perfectly within that small, awkwardly shaped bone, purely using fluoroscopy, is the real art and challenge here, especially avoiding poking out into the joint.
Absolutely. Accurate 3D placement based on 2D imaging is paramount. The risk of unrecognized screw penetration into the joint cartilage is a potential complication, particularly if using mini-open techniques where direct visualization is limited, or perhaps with less precise fluoroscopy. However, with modern high-resolution fluoroscopy units and surgeon experience, this risk is significantly reduced compared to the earlier days of the technique.
Right. You mentioned earlier that bone grafting is sometimes necessary, especially in ORF for comminuted fractures or to correct deformity like a humpback. Can we talk a bit more about the role of bone grafting?
Yes, bone grafting plays a crucial role in several scenarios. It's needed when there's actual bone loss at the fracture site due to the injury mechanism or significant comminution that creates a defect or gap after you've reduced the main fragments. It's also essential when treating an established nonunion, where you need to bridge the gap and stimulate healing. And as you mentioned, it's vital when you need to correct a malunion deformity, like surgically opening up a healed humpback. The graft fills the wedge created by the corrective osteotomy.
What does the graft actually do?
The graft serves multiple purposes. Firstly, it acts as a scaffold, providing structural support across the defect. Secondly, and importantly, it introduces osteoconductive properties, meaning it provides a physical framework or trellis for the patient's own new bone cells to grow across the gap. And depending on the type of graft, it might also provide some osteoinductive properties, meaning it contains signaling molecules that actively stimulate undifferentiated cells to become bone-forming cells, osteoblasts. Some grafts even provide osteogenic cells themselves.
So structure and stimulus. What types of bone grafts are typically used for scaphoid surgery?
We broadly divide them into non-vascularized and vascularized bone grafts. Non-vascularized grafts are simpler in concept. You harvest bone from one site, the donor site, and simply transfer it to the scaphoid, the recipient site, without maintaining its original blood supply.
Okay, standard bone graft. Examples.
Common examples include the Arus-type inlay graft. This is typically used for waist nonunions approached via a volar incision, using struts of corticocancellous bone with both a hard outer cortex and spongy inner cancellous part, placed longitudinally across the non-union site. This technique generally yields good union rates, perhaps 85–95% for waist non-unions. Another well-described non-vascularized graft is the Fisk wedge graft, or sometimes called the Matty-Roos technique. This often involves harvesting a specifically shaped trapezoidal or triangular wedge of bone, usually from the iliac crest, which is then inserted into a surgically created gap on the volar side of a malunited or non-united scaphoid to correct a humpback deformity and restore the scaphoid's normal length and alignment. When this is combined with rigid internal fixation like a screw, it can achieve very high union rates, sometimes reported as 95–100%.
How is a waist non-union managed specifically with one of these non-vascularized grafts, say, using the Fisk technique to correct a humpback?
Right, so for a waist non-union, often with some humpback deformity, a volar approach is usually preferred. The non-union site itself is meticulously debrided. That means all the fibrous scar tissue and any unhealthy sclerotic bone edges are removed using sharp osteotomes or fine burrs, taking great care not to damage the intact, healthy dorsal cortex if possible.
Cleaning it out.
Exactly, preparing a healthy bed. During this debridement, the surgeon carefully assesses the viability of the bone fragments, particularly looking for punctate bleeding from the proximal fragment, tiny spots of blood welling up, which is a good sign that it still has some blood supply remaining.
The paprika sign.
Sometimes call that, yes. If there's a humpback deformity, an osteotomy, a controlled surgical cut, is made through the malunion site, usually on the volar side, and the defect is carefully opened up like a book, correcting the angulation. The bone graft, harvested maybe from the distal radius or iliac crest, is then shaped precisely to fit the defect created or to act as the wedge maintaining the correction. It's then carefully inserted, ensuring good press-fit contact with the healthy host bone on either side. Provisional fixation is often achieved with temporary K-wires, while the definitive fixation, usually a cannulated headless screw, is inserted across the graft and fracture site.
And the outcomes for non-union surgery like this?
While the union rates are generally good, often around 90% for waist non-unions treated this way, it's important to note that patients often have some residual loss of wrist range of motion and perhaps some reduction in grip strength compared to their uninjured side, even after successful union. Treating an established non-union is always more complex than fixing an acute fracture.
You mentioned earlier that proximal pole non-unions are even more challenging, even with grafting.
They are, unfortunately. Proximal pole non-unions, which are typically approached dorsally due to access, have historically had significantly lower union rates when treated with standard non-vascularized grafts alone. Union rates are often cited in the literature as being only around 67%, maybe 70% at best.
That's quite a drop from the waist non-union rates.
It is. And this is where the concept of using a vascularized bone graft, or VBG, becomes particularly relevant and often necessary.
Vascularized bone grafting, right? This is where you transfer the bone along with its attached blood vessel, keeping it alive, correct? When is that specifically indicated over a standard non-vascularized graft?
Precisely. A VBG is indicated in situations where a standard non-vascularized graft is considered less likely to succeed. This primarily means proximal pole non-unions, and especially when there's definite suspicion or clear confirmation of a vascular necrosis, AVN, of that proximal fragment on preoperative imaging like MRI.
Because the fragment is already dead or dying.
Exactly. The fundamental idea is to bring a new living blood supply directly into the compromised avascular bone fragment alongside providing the structural bone graft itself. This aims to revitalize the fragment and promote healing where a non-vascularized graft might simply fail or become incorporated very slowly, if at all.
Does the evidence support using VBG in these cases?
Yes, quite strongly. There was a key meta-analysis by Merrill, published in the Journal of Hand Surgery American Volume back in 2002, which directly compared outcomes. It demonstrated a significantly higher union rate for proximal pole non-unions with AVN when they were treated with a vascularized bone graft, around 88% union, compared to those treated with non-vascularized bone graft, which only achieved about 50% union in that analysis.
88% versus 50%. That is a compelling difference, isn't it?
It's a dramatic difference, yes. It really highlights the biological power of bringing a dedicated blood supply to a dying bone fragment.
What are the types of vascularized grafts that are commonly used for the scaphoid? Where do they come from?
Several different techniques and donor sites have been described over the years, but some are definitely more common and widely used now. A graft based on the pronator quadratus muscle pedicle in the forearm used to be quite popular, but seems to be used less frequently today, perhaps due to variability in the vessel or technical difficulty. Probably the most common vascularized graft used currently for scaphoid non-union, particularly for proximal pole issues or when AVN is present, is a vascularized discal radius graft. This is often based on the technique described by Zeidenberg. Another very common and reliable option, particularly popular in some centers, is a vascularized graft harvested from the base of the second metacarpal bone in the hand.
Could you briefly describe the Zeidenberg technique, taking the graft from the distal radius? That sounds quite accessible.
Yes, it's an elegant technique. This graft is based on a specific small artery that runs on the back dorsal aspect of the wrist. It's usually the 12-2 intercompartmental supraretinacular artery, a small branch of the radial artery, or sometimes the 2S3 branch if the 12-2 is very small or absent. This vessel travels in the tissues just superficial to the extensor compartments, between the first and second, or second and third compartments. A dorsal-radial surgical approach is used to carefully identify and dissect out this small artery and its accompanying veins, the vascular pedicle. You follow the pedicle proximally down towards the distal radius bone, where it can be seen to supply a patch of the periosteum and underlying bone. Using a fine osteotome, or saw, a small block or section of corticocancellous bone is then very carefully harvested from the distal radius, ensuring that the vascular pedicle remains attached and intact, feeding into this piece of bone. Great care is taken not to damage this delicate pedicle.
Right.
The scaphoid nonunion site is then approached, usually dorsally as we discussed. The nonunion is thoroughly cleaned out and prepared to receive the graft. The vascularized bone graft, still attached to its artery and vein, is then gently transferred and rotated into the scaphoid nonunion site. You have to make sure the pedicle isn't kinked, stretched, or compressed during this transfer.
So you're essentially bringing a small living piece of radius bone with its own blood supply and plumbing it into the scaphoid defect.
That's exactly the principle. It brings its own perfusion. Fixation of the scaphoid fracture nonunion site, usually with a compression screw, is then performed to secure the graft firmly in place and stabilize the construct.
That's fascinating surgery, essentially replanting a piece of bone with its plumbing intact. It's clear that managing these established non-unions, especially when AVN is involved, requires complex reconstructive surgical skills. We've touched on them throughout our discussion, but let's just consolidate the conversation specifically on complications. What are the most serious issues that can arise from a scaphoid fracture, particularly if it's missed or not managed correctly initially?
Yes, the serious complications are essentially the consequences of failure to achieve timely anatomical bony union. The most significant ones we worry about are non-union itself, AVN, malunion, and ultimately the development of post-traumatic arthritis, often in the specific pattern known as SNAC wrist.
Let's take non-union first. How common is it?
Non-union, where the bone simply fails to heal, unfortunately occurs in a proportion of cases even with appropriate management, perhaps 5–10% overall for all scaphoid fractures treated. But the rate is significantly higher for fractures that were unstable to begin with, significantly displaced, or located in the proximal pole, especially if treatment was delayed or inappropriate, like inadequate casting for an unstable fracture.
Are there other risk factors for non-union?
Yes, key risk factors beyond displacement and location include certain fracture patterns, like that vertical oblique pattern we mentioned, which is prone to shear. Increasing patient age is also a factor. And crucially, smoking or any nicotine use is a major negative factor, as nicotine is a potent vasoconstrictor and significantly impairs bone healing potential. Treatment for established non-union involves the surgical strategies we've just discussed, primarily bone grafting, often vascularized for the proximal pole or if AVN is present.
And AVN, the risk we flagged right at the very beginning, how often does that actually happen?
Avascular necrosis, or AVN, remains a major concern precisely because of that vulnerable retrograde blood supply to the proximal pole. The reported incidence varies quite widely in the literature, perhaps from 13% up to 50% overall depending on the study population and fracture types included. But it's particularly high figures. Up to 50% are often quoted specifically for proximal pole fractures, and the risk increases dramatically with the amount of initial displacement.
Okay.
As cited in the source material, it can even approach 100% in fractures involving the most proximal fifth of the scaphoid if they are treated with immobilization alone, without surgical fixation to restore stability and potentially improve perfusion.
And it's sneaky, isn't it? It doesn't show up immediately.
That's the insidious nature of AVN. It often doesn't become apparent on standard x-rays until months after the initial injury. This is because it takes time for the bone to slowly lose its viability, die, and then either collapse or become relatively denser, sclerotic, compared to the surrounding living bone, which undergoes normal disuse osteoporosis in a cast.
Right.
This delay in radiographic appearance really underscores why early, accurate diagnosis of the fracture type and risk factors, followed by appropriate initial management, often surgery for proximal pole fractures, is absolutely critical for trying to prevent this devastating complication in the first place.
Hmm.
Once AVN is established, managing it adds significant complexity and uncertainty to the treatment.
What about malunion when it does heal, but heals in the wrong position?
Malunion, which most commonly presents as that humpback deformity with excessive flexion at the fracture site, giving an intrascaphoid angle greater than 35 degrees on the lateral view, typically occurs when an unstable or displaced fracture is treated non-operatively, or perhaps when the reduction achieved initially is lost within the cast and the bone then heals in that abnormal flexed position.
What's the consequence of it healing bent like that?
The natural history, the long-term consequence of this scaphoid malunion, is progressive carpal instability. Specifically, it tends to lead to that dizzy deformity pattern we mentioned, where the lunate bone tilts backwards. This abnormal alignment is followed by altered joint mechanics, carpal collapse over time, increasing wrist pain, reduced range of motion, especially extension, decreased grip strength, and inevitably the development of post-traumatic osteoarthritis.
And the final stage of that.
It typically starts between the tip of the radial styloid and the scaphoid itself, then progresses to involve the scaphocapitate joint between the scaphoid and the large capitate bone in the middle of the wrist, and finally involves the capitolunate joint. By the time a SNAC wrist pattern is fully established, the joint surfaces are significantly damaged. At this point, surgery aimed at achieving scaphoid union is often no longer appropriate or even possible, and treatment usually shifts towards salvage procedures like wrist fusions or proximal row carbectomy. It really represents the failure to prevent the long-term consequences of the initial scaphoid problem.
A sobering endpoint. Are there other complications to be aware of, perhaps arising from the treatment itself?
Yes, certainly. Other potential complications include delayed union, which is distinct from non-union. This is where healing takes significantly longer than expected, but is still biologically occurring. Sometimes interventions like bone stimulators using pulsed electromagnetic fields are tried in these cases, although the evidence for their effectiveness is somewhat limited and not universally accepted. Hardware-related issues are possible with surgery, such as irritation from a prominent screw, or more seriously, subchondral bone penetration by the screw tip, which can lead to cartilage damage on the opposing joint surface and subsequent arthrosis. While less common with modern screw designs and careful fluoroscopic guidance, it can occur and might require revision surgery or implant removal. Infection is always a potential risk with any surgical procedure, though thankfully it's relatively infrequent after scaphoid surgery. And despite achieving successful bony union, some patients may unfortunately experience persistent symptoms like chronic pain, residual stiffness, limiting function, or reduced grip strength compared to their pre-injury state. It's worth noting, one summary cited in the provided material mentioned overall serious complication rates being perhaps around 14% in patients managed operatively versus 18% reporting cast-related complications like stiffness, skin issues, nerve compression in the non-operative treatment group. This suggests risks exist down both pathways, but importantly, the nature of the potential complications differs significantly. Operative intervention is often chosen specifically to mitigate the higher risks of non-union and AVN inherent to the unstable fracture types, even though surgery carries its own set of potential, albeit different risks.
That paints a very clear picture of why prevention, early diagnosis, and diligent appropriate management are so incredibly crucial to avoid these serious, potentially life-altering long-term issues. So, turning towards the positive, what's the general prognosis and recovery outlook for a scaphoid fracture that is treated appropriately and in a timely manner?
Well, with timely and appropriate management tailored to the specific fracture type, the prognosis for most scaphoid fractures is generally good, particularly for those stable, undisplaced fractures treated effectively with casting.
What influences the outcome?
Key factors influencing the final outcome include, naturally, the initial fracture type and its location, proximal pole always being less favorable, the presence and degree of displacement or comminution, the presence of any associated ligament injury causing carpal instability, the chosen treatment method, cast versus surgery, and importantly, patient factors like age, general health, adherence to treatment, or particularly their smoking status.
You mentioned surgery might get people back quicker.
Yes, surgical treatment, when indicated and performed successfully, has been shown in several meta-analyses to be associated with a more rapid return to work and sorting activities compared to prolonged non-surgical management in a cast, even for some fractures that might otherwise have healed in a cast eventually. That faster return is often a key factor in the decision-making for athletes or manual laborers.
What's a typical recovery timeline look like?
The bone healing time itself, achieving solid union, typically ranges from 6 to 12 weeks, sometimes longer for proximal pole fractures, depending on the location and the type of treatment. However, achieving full functional recovery, regaining wrist range of motion, grip strength, and confidence for demanding activities usually takes significantly longer, often several months of dedicated rehabilitation after the cast is removed or after surgery.
So patience is needed.
Definitely. Follow-up with periodic X-rays or sometimes CT scans is needed to monitor the union progress until it's confirmed solid. While some patients may experience some minor residual stiffness or perhaps aching in the wrist, especially in cold weather or after heavy use, with successful union and appropriate physiotherapy, chronic disabling pain and major functional limitations are thankfully infrequent.
So, while it's undoubtedly a challenging fracture, good outcomes are very much achievable with the right approach. Finally, let's think about prevention. Are there practical steps people can take to reduce their risk of getting this injury in the first place? Or perhaps reduce the risk of complications if they do sustain one?
Yes, there are certainly steps one can consider at different stages. Prevention of the initial injury starts with basic safety precautions, especially in activities known to have a high risk of falls onto an outstretched hand. Things like snowboarding, skateboarding, rollerblading, or certain contact sports come to mind.
Wrist guards.
Exactly. Wearing well-fitting wrist guards during these activities can significantly absorb the impact force and, crucially, limit the degree of wrist hyperextension during a fall, which can potentially prevent the fracture from occurring. Also, just using appropriate safety equipment generally and ensuring safe environments during these activities is key.
What about people who are already involved in sports or have had previous wrist issues?
For individuals involved heavily in sports or demanding manual labor, especially if they have a history of previous wrist pain or perhaps minor injuries, tailored training and rehabilitation programs can be beneficial. This might include exercises to improve wrist proprioception, your sense of joint position, strengthening the muscles of the forearm and thumb that support the wrist, and maintaining good flexibility.
And falling technique.
Yes, somewhat counterintuitively, educating athletes and others at risk on techniques to fall more safely, learning how to tuck and roll, for instance, to absorb the impact over a larger body area rather than landing directly onto a single outstretched hand, can be a very valuable preventative measure.
Avoiding activities that cause pain or strain seems pretty sensible, too.
Absolutely. If you start experiencing persistent wrist pain or discomfort, particularly after a fall or even just a minor incident, it's wise to avoid activities that clearly exacerbate it. Potentially using a supportive wrist splint temporarily might help settle things down and prevent a minor issue from becoming a more significant injury.
And seeking help if it persists.
Crucially, yes. After any wrist injury, even if it's initially dismissed as just a sprain, paying close attention to persistent symptoms, especially that tenderness in the anatomical snuff box, and seeking prompt further medical evaluation and appropriate imaging if it doesn't settle quickly, is paramount to avoid a missed or delayed diagnosis. And of course, diligent follow-up care and maintaining open communication with your healthcare provider throughout the treatment and recovery process are essential to catch any potential non-unions or other complications early before they become major, harder-to-fix problems.
Those are really concrete, actionable steps listeners can consider. We've covered a huge landscape today, haven't we? From the Scaphoid's really tricky anatomy and blood supply, through all the nuances of diagnosis, classification, the different surgical techniques, including complex vascularized grafting, and exploring those potentially devastating complications. Let's try and boil this all down to the absolute most crucial takeaways that you should remember from this deep dive.
Right. Let's try and crystallize it. First, after any fall into an outstretched hand, you must always suspect a scaphoid fracture if there's tenderness in the anatomical snuff box, period. Regardless of what the initial x-rays might show or fail to show, high suspicion is the very first step to avoiding disaster down the line.
Okay, suspicion first. Second key takeaway.
Second, don't rely solely on standard basic x-rays if your clinical suspicion remains high. Be prepared to utilize advanced imaging promptly, Use CT scanning for accurately assessing displacement, combination, and monitoring union, and especially use MRI for definitively diagnosing those occult fractures or assessing for AVN when initial x-rays are negative.
Okay.
Don't fall back on the 2-week wait.
Right. Image appropriately.
Third, classification matters deeply because it guides treatment. Understand that unstable fractures, displaced 1 millimeter angulated 35 degrees, comminuted vertically oblique patterns, and particularly all proximal pole fractures, carry a significantly high risk of nonunion and AVN. These types generally require surgical fixation for the best, most predictable outcome.
Stable versus unstable, location, location, location. Fourth crucial point.
Fourth, complications like nonunion, AVN, malunion, and the end-stage SNIC wrist are serious life-changing problems, but they're often preventable. Timely, accurate diagnosis followed immediately by appropriate evidence-based management casting for the truly stable, surgery for the unstable or high risk is the absolute key to mitigating these long-term risks.
Okay, prevention is key. And finally,
perhaps linking back to the start, prevention where possible through protective measures like wrist guards and high-risk activities and learning safer falling techniques, combined with diligent follow-up care and simply listening to your body after any wrist injury, plays a vital role in maintaining long-term wrist health and function. Don't ignore persistent wrist pain after a fall.
excellent summary. That gives you a really clear, deep understanding of why the scaphoid fracture is absolutely not just a simple break and what really needs to be done to manage it effectively. If you found this deep dive valuable, please do consider sharing it with your colleagues on platforms like LinkedIn or X, and perhaps leaving us a rating. It genuinely helps us reach more professionals who could benefit from this information. And a huge thank you again to Professor Mo Imam for sharing your incredible expertise and guiding us through this very complex topic with such remarkable clarity.
It's been my pleasure. Important topic.
So as we wrap up, and considering all the hidden dangers and potentially severe long-term consequences we've discussed today for this seemingly quite minor cone, perhaps the final thought to leave you with is this. In the face of such significant potential functional loss down the line, are we consistently in our clinics, on our sports fields, or perhaps in our workplaces, giving every single wrist injury the level of initial attention, diagnostic rigor, and timely follow-through that the humble yet absolutely critical scaphoid bone truly demands?